know it's July. Hopefully, everybody's having reasonable temperatures wherever they are. Today, we have two very exciting guests for our topic on the brain and migraine, endometriosis in the brain, and hormonal headache, and the neurology of chronic pain. So today we welcome Dr. Olivia Begas-Sedem and Audrey Craven. I'm going to say a little bit about both of you. Dr. Olivia is a board certified neurologist and headache specialist and the medical director of the Institute for Headache and Brain Health in Stamford, Connecticut. She is also the associate professor of neurology at University of Connecticut and is a leading voice worldwide in hormonal headache care. She serves on the AAN Brain Health Committee and IHS Education Committee and has also co-authored Headache, What Do I Do Now? Question mark. And she also vice chairs the Global Patient Advocacy Coalition for Headache, GPACH. Okay. Audrey Craven has come to us today from Ireland. She's the patient advocate and president of the Migraine Association of Ireland. She founded the organization in 1994 and has lived with migraine her entire life, unfortunately. She also chairs the Global Patient Advocacy Coalition for Headache and has experienced menstrual-related migraine, pregnancy-related changes, and perimenopausal worsening of symptoms as well. And so we welcome you today, Audrey. Thanks for logging in the evening for us.
My
And
pleasure.
we'd love to start, Audrey, with your story for all of those patients watching, who have migraine or maybe have a loved one affected by it and are tuning in today. And by the way, if you are a loved one of a patient, we will have this available for you guys to watch later. If someone is away or in a meeting or working, we can make this available to you later as long as you register for the email link. So Audrey, please give us an overview. Tell us your story.
Thank you very much for this opportunity and greetings to everyone. The first thing I would say is you are not alone. It's a very isolating condition if you have severe migraine and headache disorders. You're not hidden, you're not visible, I should say, you are hidden. You're in the darkened room, away from everybody, and you are quite nervous that what you have is something more sinister than this very severe migraine attack. We know it's a brain disorder, but just to outline my own story, can I start with a young woman with 3 young children lying on the bathroom floor, unable to move or speak? That was me when my 3 children were young. I was absolutely terrified, as were my very young children. And that led me on the story of getting hold of my migraine, learning to manage it, but first of all, having it properly diagnosed. When I was a small child, I had what's now known as abdominal migraine. It presented in my tummy only. No headache presented. Then, as a teenager, the headache and the aura, which I'm sure both doctors will explain later here on this webinar, that presented, and it certainly affected me during my studies when I was at college. It also affected my career. I had studied hotel management and I was working very unsocial hours, and I was very nervous about going for promotion or any sort of career advancement because, of course, the migraine brain loves regularity, as I was to discover as my life progressed. Then when my children got older and I had a diagnosis, I live in Dublin, Ireland. I had to go to London for a proper diagnosis back in 1993. I made a little promise that if I ever got a handle on this dreadful affliction, that I would do something about the lack of information and accurate, reliable information, and hope to build capacity to all those affected. So in 1990, as a basilar migraine, I learned how to manage it and live life defensively. That meant staying hydrated. It meant eating regularly. We know now that the migraine brain loves regularity. So that means managing your stress, being very careful that we're going to hear a lot in this webinar about hormones and how they are related. So that means not having a very stressful time when you're premenstrual. So if you have a deadline in your project at work, that's not the time to be socializing, I'm afraid. I'm sorry to be a party pooper, but that is the time when you have to protect yourself. And this is all part of the journey of patient empowerment, learning what your triggers are, managing and being very careful to keep a diary, we would say, in this part of the world. I think in the Americas, you say a calendar. We are, as human beings, programmed to forget pain. I often think there would only be one child in a family if we weren't programmed to forget pain. So I really advise you to keep a very clear note of how you were afflicted and try and marry that when you look back at your diary. Was that premenstrual? Was that during my period time? Or we know that men suffer too, but we also know that 3 times more women than men suffer. And therein lies the hormonal part of the story. As I went on in life and came to perimenopause and came to menopause, it got significantly worse, which meant that my life narrowed down. And I remember being on a television program here in Ireland to promote the Migraine Association of Ireland that I had founded in 1994. And I remember being violently sick at 2 o'clock in the afternoon, and the program started at 3. I would humorously say now that I was dead at 2 and live at 3. And I can attribute that to the changes in the treatments and the medication. I had this subcut of sumatriptan and I was able to use that. And as a result, I was able to speak coherently and I hope reasonably intelligently and get the message across that you are not alone, that there is help. But we are so desperate for reliable, accurate information that I do recommend that you are very careful of your sources, that you check them, that you make sure, for want of another word, that they are kosher, that they are properly, that a proper medical advice is sought, that it is research based, and we know the importance of peer-to-peer support. So when you're on your journey, be it in a very small village or be in an urban area, you have to go on that journey. But we know that the migraine brain will pay attention to so many things. Please know that you have to focus on your particular attack. Try and understand it. Try not to feel guilty when you can't make the party that you had hoped to make within the family. Try not to feel guilty about not being able to organize your child's birthday party or some other big family event, but do apply your considerable intelligence to what you can do to mitigate. So I would say that migraine is common, it's disabling, and it's treatable. And I'm living proof of that. And just Dr. Goldstein to say a little bit further about my own journey as I learned to manage it. Back in the year 2000, the World Health Organization, for the very first time, recognize migraine for the disability that it is. We now know it's the third leading cause of disability in the world. And the Global Patient Advocacy Coalition for Headache is addressing that global aspect, but we're acting locally and thinking globally. But it's really important to know how vital it is that you get hold of this. So in 2000, I was the patient who spoke at that. And the story I told at that event was of a committee member of Migraine Ireland, a young man, 36 years of age. He, an engineer with the electricity supply company, he was forever missing work because of his very severe migraine attacks. He had a tumor on his thyroid, and he underwent a 10-hour operation to remove it. I phoned his home. We didn't have mobile phones then. I phoned his home and checked with him how he was recovering. And his wife told me he had gone into work. In 2000, I was able to say at that meeting that the reason he went into work was so that his employers would know that he was genuine about his migraine attack. When he had the tumor removed from his thyroid, he was able to think, he was able to function. And I would say, as a patient advocate, it really is about your ability to function. So, what did my journey look like? It looked like from darkness into light. And I do encourage anybody who is a loved one or who is suffering in silence and isolation. In 2025, there has never been a better time for you to get hold of that, and we will help you on your journey.
That's beautiful. Thank you so much, Audrey, for sharing and giving so many pointers for the patients watching. I think it's quite a journey, and everyone's looking for resources, right? And we're lucky, at least in 2025, that so many people are connecting peer to peer, as you said, and there's a lot of advocacy work that you're doing, and that we can be really proud of, that patients can really connect on these. So let's go a little bit, dive into a little bit more about, the connection between hormones and inflammation in the brain. We know that if I put up a hormone pathway right now, we know that there's different times of the month during the normal menstrual cycle. Once someone is menstruating regularly, we know that even in the years of pre-puberty or as puberty is starting, the hormone fluctuations may be a bit more wild and erratic. Once there's a normal set menstrual cycle of around 28 to 30 days, there's a couple of phases of the cycle. In the beginning, estrogen is quite low. In the middle of the cycle, there's a bump in testosterone, and then it's quite level. And on the second phase of the cycle, there's two areas where estrogen surges and then progesterone slowly rises from ovulation all the way up to the next menstrual period. And right before menses occurs, right before the period or the menstruation or the bleeding happens, there's actually a drastic drop in hormones, a plummet, that, really, I think a lot of patients are quite symptomatic in this time, with the plummet. And I find in my own patient population with endometriosis and pelvic diseases that those bumps and surges in estrogen are quite a symptomatic time, whether it's for autoimmune disorders, for migraine, and even for pelvic pain and disorders like that. Um, and so, Dr. Begasadem, can you speak a little bit about the sort of the interaction between those hormones and maybe serotonin in the brain, or, what they're experiencing in these moments?
Yeah, and thank you so much for having me, and to Audrey for sharing a story and highlighting. I mean, it's clear from Audrey's story the intricate relationship between migraine and hormones, right? And actually, I'm glad you mentioned, not that I wish it on anyone, but worsening around perimenopausal transition, because oftentimes people think, oh, I'm going to reach menopause, I'll have no more migraine ever. 67% of women have an improvement of migraine after menopause, but oftentimes with a worsening during the perimenopausal transition. And about 10% of women develop new migraine after menopause. So I think it's like listening to you, Audrey, made me think of that. So I wanted to put it out there. Not avoiding your question. Is a lot of relationship between hormones and brain function. In the brain, we think of estradiol mostly as protected in a sense with anti-inflammatory effect. When there's a drop in estrogen during the times you mentioned, there's increased susceptibility to neuroinflammation, pain, headache, cognitive changes, mood changes. And we have neuroimaging studies that show that hormone fluctuation can drive dynamic reorganization in the brain networks, especially in the regions involved with emotion, cognition, pain processing. So when there's a peak in estrogen, we have better functional connectivity and cognitive performance. When there's a drop in estrogen, there is increased sensitivity of the brain to stress, inflammation, pain, and headaches. In terms of serotonin and estrogen, as you mentioned, estrogen has an influence on serotonin production and regulation. So serotonin is a neurotransmitter, a little brain molecule per se, it's also in the gut, but it's a key neurotransmitter in the descending pain inhibitory pathway. So it helps basically mitigate pain. We know that fluctuation in estrogen can cause dysregulation of pain modulation, and then it lowers the pain threshold. Lots of talk about estrogen. We also know that progesterone is actually protective in the terms of brain inflammation and pain and headaches too.
Amazing. And we were talking earlier about something that we feel, patients should know about migraine and estrogen components in commonly prescribed medications. So can you say a little bit about that just for patients that may be unaware?
Yeah, actually, talking about that too. So we talked about estrogen in different ways. Also, estrogen has effect on the glutaminergic receptors. It activates them, and this has a main receptors, some of the main receptors for increased excitation of the brain, and these are responsible for what we call aura, which are transient neurological symptoms like vision changes before the headache phase. And that's due to cortical spreading depression, excitation of the neurons moving forward. So that's another relationship between estrogen, migraine, is that increased estrogen may be protective for pain, but actually puts you more at risk of aura. In terms of aura, so people with migraine in general have women of reproductive age have a very low risk of stroke. Women with migraine have about twice that risk of stroke, pure migraine. So we talk between average risk, absolute risk, 3 to 4 in 100,000. That's doubled with migraine. That risk gets bigger if people have migraine with aura. So it's about 18 to 40 in 100,000 women. If you take estrogen-containing therapy, that risk significantly increase, and even more, hopefully not with tobacco combined with that. And that dose is estrogen dependent. So if I'm not mistaken, Dr. Goldstein, correct me if I'm wrong, in the ACOG guidelines, they prefer no estrogen for migraine with aura. In the neurology and headache guidelines, they say avoid if you can, but if it's absolutely necessary, because we know it's dose dependent, the lowest dose of estrogen, the better. But in general, it's important to try to avoid estrogen in people with migraine with aura.
And we're talking about synthetic estrogen. Does the same apply for patients on bioidentical hormone replacement in menopause on very low doses?
I wish I had that
We wish we had that. Yeah.
answer
Yeah.
for you, right? Because I tested it mostly on these studies have been mostly done on older school synthetic, although there's some study with 20 micrograms. But yeah, I wish I knew that answer. And we don't have also too much either, right? Because we know that risk is slightly increase of migraine and stroke in women under 50, but it's not really clear above 50. And that may also be because then above 50, there's other cardiovascular risk factors that are so much stronger, you don't pick an association anymore. But migraine is not a contraindication to hormone replacement therapy in perimenopausal transition. I'm sorry I have to put it out there, but I see women who are suffering so much and nothing is given to them because they have migraine, but it's not a contraindication anyway.
Perfect. And then to just go over the symptoms of aura, you mentioned visual changes, so spotty vision, nausea, vomiting, pre-migraine.
So
Can you go through all the like
yeah,
main symptoms of aura for anyone watching?
yeah. And actually I would call Audrey on this first because she mentioned basilar migraine, which I know now we call it migraine with brainstem aura, but I'm really glad you talked about it, Audrey, because it's oftentimes not missed and not diagnosed. If you want to talk about your own experience with aura, and then I'll say a little bit more.
Yes, well, I had never heard of basilar migraine. As I said in the introduction, it was diagnosed in London by Frank Clifford Rose, whom you will know from the textbooks, was a very early proponent of and definitely did a lot of work on migraine. What I found was, as you described the aura, I got about a half an hour warning and then into the very severe headache and then the vomiting. But maybe 4 times out of 5, that would be 4 attacks out of 5, I wouldn't be able to speak and neither was I able to move. And it felt like a stroke. It terrified me. Frank Clifford Rose in London said to me that if it was any comfort to me, that I was one of the most worst affected patients he'd ever encountered, but he was able to diagnose it. And I make a plea here for having an accurate diagnosis, because I'm sure you'd like to say something not just about basilar, but also about the importance of the story told by the patient to the healthcare provider, because there's no test for migraine.
And
Yeah.
Audrey, how long would that last, those sensation?
Well, the aura that I described, possibly an hour, 40 minutes more likely. But if I woke up in the morning, I had no chance of taking any treatment. I was actually disabled. And that was the most terrifying. And in fact, that's when my children, I think, got the biggest shock, because I had to be taken to hospital by ambulance, but I couldn't walk down the stairs. I had to be carried down the stairs. So that, to answer your question, Dr. Goldstein, that lasted for about 8 hours.
Wow. Must have been terrifying. I know, for everyone
But
involved.
once I had the diagnosis and I knew what it was, and that, could I make a plea here, because I'm so interested to know how you both respond to that, but particularly Dr. Dehaene. One of the things that I think it's really important to know, that when you live with a very severe unknown or underdiagnosed or under managed disorder, you really want a good explanation. And when we come to see somebody like both of you, healthcare providers, we're not coming for a magic cure. That would be wonderful. But really, we want your expertise, but we want you to work with us in partnership and know that you are going to take an interest in what is disabling us. And that is really so vital. And I'm sure many of your participants in this webinar will know what I'm talking about. When you're terrified, to see somebody like Dr. Olivia Bagassa-Daheim and you, Dr. Goldstein, who is interested in the patient and who will work with them, that is.
Yeah. No, that's very important, and keep trying. It's such a, you are dealing with all of these symptoms, and it's hard enough, and all the impact on all aspects of life. And despite that, I think it's worth to find the energy to keep pushing until you find a healthcare professional that can work with you. It's extra work sometimes, but I think it's important. In terms of your question about aura, so migraine has four phases. Some people have, not everybody has the four phases, thankfully, but people can have a prodrome, like the food cravings, increased urination, increased yawning, cognitive changes, language issues, neck stiffness, before what people could like think of migraine headache starts. Then about some people can have aura. So aura are usually about 1 hour for most people, but they're gradually progressive symptoms. For at least some of them are gradually progressive. They're not sudden over, about 5 minutes. They last about 1 hour. The most common ones are vision changes, but people can have sensory issues like tingling, numbness. Some people can have language, speak difficulty, vertigo, dizziness, weakness on one side of the body. And then people then go to have the migraine headaches. So the moderate to severe headache interfering with regular activities that are associated with light and noise sensitivity, nausea, and vomiting. And then people can have a postdrome, which some people call the migraine hangover, although most people with migraine will not touch glass of alcohol dealing with all of this. But fatigue, neck stiffness, cognitive changes. This is kind of like the full spectrum of a migraine attack.
It's a lot, right? And
Yeah.
very little control over it but thankfully there's specialists like you know, working through all of these things. Um, so let's talk about what neurologists observe that we may miss as gynecologists, or what we could look out for. Um, you know, what are a couple of little questions we can ask patients to screen them for this, and then maybe send them in case, you know, we're the sort of first line of who they're seeing, you know?
Yeah, no, I appreciate that. And you're familiar with it because endometriosis is also terribly underdiagnosed. We have kind of the same time to diagnosis of migraine, so screening is important. It's an easy way to screen, and it's the ID migraine. It was created by Dr. Lipton, who has no rights in it, so anyone can use it. And it's 3 questions. During the past 3 months, did you have any of the following with your headaches? 1, nausea. 2, light bothering you. And 3, your headaches limited your ability to work, study, do what you needed to do. So if there's 2 out of 3, yes, there's a 75% chance of having migraine. So that doesn't take too long, hopefully, and then people can get referred and get a formal diagnosis and get better care. And another thing that I think gets oftentimes missed with a lot of specialties, and I think it's important to ask, is how are you coping? Because we talk about symptoms, but then it's such a, and it is, that's why when I was thinking about this webinar, there's so many similarities about endometriosis and migraine that tend to be invisible to other people, cause extreme isolation, suffering, self-guilt on top of everything. Like asking patients, how are you coping? And getting an understanding, how does it affect in day-to-day life, at work, at school, and is there anything we can help to support function too?
Hmm. Absolutely. And I think I see, you know, so much of, and a part of what I do, I mean, I do a lot of surgery for endometriosis, but I also do a lot of sort of lifestyle and holistic and wellness and management on all of the coping mechanisms, right? And I am well aware that, just as you are with migraine medication, that there isn't a perfect, I wish there was a perfect magical fix all the time that I could give, and a perfect pill and a perfect this. But it is the interplay between everything we put in our bodies and the environment. And Audrey, as you were speaking to earlier, and the stress. And I say the same thing to my patients. Like when we look at a cycle that's been very painful and they were doing very well for a while, what happened in the last 6 weeks leading up to that? And, they'll say, well, the last week I've been very relaxed. And that may be great. But if there was 6 weeks of stressors and stressors and stressors, and then finally a period of relaxation, I find in my endometriosis patients that, or chronic pain, is that, the body, when it's given that relaxation mode, then things will act up because it sort of has a moment of rest that can take the stronghold. When you're sort of in a fight or flight stressful mode, then many times you push through and you put all of your defense mechanisms up. And then once you're finally sort of quieting down and resting, then we notice these things flare more. I see it a lot around the holidays, around final exams for college kids, periodic predictable times of the year that are very high stress. And then even when the downplay afterwards may be better in period of stress, that's when your body is sort of catching up with everything it's had to deal with. And so, Audrey, I think that was beautiful what you said earlier, is that when you have a big presentation coming up and you know that you're putting a lot of stress on yourself, it's not also the time to go out for a big event and go out with family and then eat a whole bunch of inflammatory foods plus have the wine, as much as, we may want a glass of wine. But, it's the interplay of all of the things together. And I think, even when I'm coaching a lot of college kids, or, oh, I can't eat the right things in the dining hall, and I can't, and then we try to work on, okay, what things can we do? What can we implement that we have? And then sort of working around all of those triggers to try to reduce them as much as possible. Or if you know that you're going to have exposure to one or two of them, then really try to control the other ones, right? And I think that's part of this whole package, or ability to have all of these tools in your toolkit, I like to say to patients.
It's
Yeah,
very important sorry, Olivia, it's very important not to feel helpless and hopeless.
Mhm.
And I particularly like what you're saying. And also, I think when you have a healthcare provider who's knowledgeable and interested, they don't have the magic pill or the magic cure. You don't have it for endometriosis, we don't have it for migraine. But we can get to a place where we can manage it. But the one thing I always found very difficult, and I just want to say this by way of reassurance to people with loved ones who are suffering at the moment, is really be absolutely certain that you have a brain disorder. You have a propensity for this. Dr. Olivia would give you the stats on that. But you have a neurological, biological disorder, and looking for a coat peg to blame your attack on. I totally hear what you're saying about after a period of stress. I think in the headache world, we would call it, would be known, I think, as the Saturday headache, euphemistically.
Mhm.
And when the stress is gone and you're relaxing. So just what you were saying there about the holiday or the stress was over, Dr. Goldstein. That's quite typical. It's something we hear. But also, the one thing I have found very difficult all my life is coping with the guilt part. What coat peg could I hang this on? What did I do that brought this to? It's like the migraine threshold, which Dr. Olivia can speak to, but I know the prodromes that you refer to, and then the postdromes. I know a couple of headache specialists who make the diagnosis of, retrospectively, of course, on how severe the migraine is, depending on how awful the hangover is. If the worse the attack, the more disabling and the most upsetting part. Okay, you're so relieved the attack is over, but you're like a washed out rag for about a week. And then you're back into another attack. And I think that's where, in my lifetime, what made me firmly resolve to try and do something about having patient advocacy and promoting health education and promoting education in this field because it's not normally taken seriously. And we're trying to move the compass needle on that.
Absolutely. Yeah, I think that, it's the conversation has to always continue, right? And I think having these more relatable events for everyone to hear about is really important so that patients do know they're not alone on any of these, and there is the support. And I think the crosstalk is very important. I learn from my patients all the time. Every day I learn things from them, and they come in and they say all of the things in the toolkit they're doing, and they're working so hard at it, and taking all of these different supplements and doing all these dietary changes. And when they come in with a binder and everything is organized and this and it's all tabulated, and there's, I know it's the whole life is really revolving around this, and it's awful to see. And that's something that I wish I can get rid of those things, but that kind of organization around every minute of the life and all of the input and output on everything you're doing, I think it's patients are always working tirelessly to handle this on their own. And if at best we can take some of that pressure off with acknowledgement, diagnosis, and then some options, that's the best thing we can do, right? So, and then referral to the right people that really have some strategies, right? We were talking before, Dr. Olivia, about diagnosis at different places, but sometimes there's not always strategies when you get a diagnosis, right?
Yeah, and to me, sometimes that's the most important, like asking patients, what are your expectations of the visit? What are your goals? Because we may have our own preconceived ideas, like, oh, they want a diagnosis and then they want treatment. But to me, treatment is only so helpful if it doesn't lead to improve quality of life, improve function, helping patients actually reach their goals. Yeah.
And so, what kind of questions can they ask, or what, we talked about some of the symptoms, the aura symptoms that and the prodrome and everything. Um, so when we were talking about the diary earlier, and for them tracking their symptoms and really writing it down, any of either of you could answer, what are the things that are most helpful when diagnosing this? Is it the timeline, the actual symptoms on when those are occurring? Like you said before, how often in the last 3 months, and if it's debilitating for work, these kind of things. What are the best sort of resources that patients could write down and give you?
Yeah. I think it's the frequency, like write down when attack happen, the symptoms impact on function. And it could be, anything like, oh, I love ballet, I cannot go dancing anymore, or work, medication straight. It's very, very helpful for me to have an actual list of the medication and do straight, so we don't do this again. But if we don't know, obviously, we don't. And sometimes if you go to CVS, Walgreens, they can pull a list of the medications you have been prescribed, at least for the prescribed medication. But for a headache specialist, if this is already the best we can get. In terms of red flags, right, there's a diagnosis of migraine, and then there's a red flag. So it's not always a migraine, unfortunately. And because people don't understand migraine, sometimes because you have a history of migraine, they don't know what it is. They call it migraine or complex migraines. Actually, no diagnosis of complex migraine. So there's some things we have to think about in terms of red flags. One of the red flags is pregnancy or postpartum recent pregnancy. And having a history of migraine actually puts people at higher risk of complications in pregnancy, right? The high risk of headaches due to something else, like gestational hypertension, like high blood pressure, preeclampsia, all those stuff that we worry about pregnancy. So any new change of headache in pregnancy require immediate attention. We cannot put it on migraine. And for 87% of women, pregnancy is protective. against migraine. Another big red flag that needs prompt attention is what we call thunderclap headache. So it's headache reaching peak maximal intensity in less than 1 minute. It's like explosive all of a sudden. So if I had to pick two for this talk to really be careful with, it would be those two red flags.
That's a great one. I think it's really important in the obstetric world. And I mean, I think patients are often taught that, but maybe it's not stressed as much. And so, for all of our listeners, again, 87% of migraine will improve with pregnancy, right? And so what Dr. Olivia is saying is that any sign of increasing headache should be an immediate call to your obstetrician. If you have an OB and you're seeing someone in pregnancy, even if you're just had the baby or postpartum, we still look at things like preeclampsia or high blood pressure related disorders of pregnancy, even postpartum, and these can still be a sign of a severe problem with your blood pressure and a neurologic event that's worrisome for things like stroke or ischemic events, even in pregnancy. And so yeah, I think those are things not to miss, obviously, and the thunderclap headache, of course. And let's see, what are some options for collaboration, on managing hormone-linked neurologic disorders? What are some common things that you like to do with patients for those experiencing menstrual migraine or PMDD with migraine right before the cycle? What are some of the strategies that you like to employ, that we were talking about? What if maybe we can say the ones without aura and the ones with aura, maybe is easier way to do it. But
And we have to do this together for
yeah, yeah.
this and in the real world. So in the migraine world, we know that migraine attacks that are related to the menstrual cycle are more severe, longer, more disabling, more intense, and harder to treat that migraine attack outside of the menstrual cycle. And same thing goes around the perimenopausal transition. So we take this seriously because they tend to be longer, and for some women, at least they're predictable. So usually it happens on the 2 days before day one of the menses up to day three of the menses. So for women for regular cycles, at least we know. So we plan in advance. So the first line usually is what we call mini prevention. So long-acting NSAIDs or long-acting triptans that we start right before the expected time. And then some women, so usually we do not start anything hormonal on the basis of migraine. That being said, a lot of women are already on birth control or are considering birth control. So sometimes the conversation, adjusting it, because from the headache standpoint, at least what tricks the brain is a drop in estrogen. So then anything continuous birth control, anything to try to mitigate this fluctuation, this drop. So like continuous birth control for people on with aura. We talked about avoiding estrogen, so continuous birth control, and you'll talk about progesterone only. The one thing usually, at least for me, I've seen people do better with stuff like medroxy, progesterone, norethindrone. If some people say they've found some patients do better on the SLIND, but to me it's kind of hit and miss. I still think there is pretty too much variation. Then some people consider the Mirena when they have aura, but it's thought to be headache neutral. It's not thought to help with menstrual migraine. And in my experience, usually the Nesplanon has not been the best. There's a lot of headache side effects. So I know people try sometimes also to go away from the pill, but this I kind of, in my experience, but we need you to comment more
Sure.
on the hormone treatment.
Sure. Yeah, and it makes sense, right? So if for a patient without aura, um, if they tolerate low dose birth control that may be combined with estrogen, progesterone, something continuous, what you're saying is to avoid that drop in estrogen. So, and I tell this to patients all the time. I speak about this all the time in the office, actually. I think patients are not, it's not always taught how birth control is actually working. Birth control is introducing a pseudo pregnancy state in your brain so that your body does not trigger the ovaries to produce these hormones and to ovulate. So when you're on a birth control, your ovaries are not ovulating. Your brain is not triggering your ovaries to ovulate. And so there's no practice run happening with the ovaries ovulating, the lining building up, then the lining shedding. What's actually happening on a birth control whenever you have a bleed on a birth control or period on a birth control is your brain is just seeing lack of estrogen, like you're saying, for a few days, and then you're having a breakthrough bleed. It's not a buildup of a physiologic lining that is promoting pregnancy. It's a breakthrough bleed of lack of hormone and then an actual bleed that's happening from estrogen withdrawal. So the same thing I say to my patients with endometriosis or chronic pelvic pain or conditions like this is that if they don't tolerate that bleed and that drop really bothers them, then I do recommend something continuous that can avoid those moments. There's no real gain by having those, it's really sort of more of a cause of suffering than your body actually doing something physiologic that's good, right? And so if those are tolerated, those are an option. The progesterone only ones that you were talking about can be taken continuously every day. There's all different doses of norethindrone and progesterone only type pills. And I would agree with you on the Slind. It's sort of hit or miss whether patients tolerate different formulations. Unfortunately, like we were talking earlier, there's not a magic birth control that everyone loves. All of them may have side effects, and it really depends on the patient profile and how they experience it and what they feel. Mirena or the intrauterine devices, while they help thin the lining and they act progesterone only on the lining on some of them, and the one that's non-hormonal is copper, those do not affect, they're not strong enough systemically in the body to actually affect the ovaries and stop ovulation. So, what that means to the brain is that the ovaries are still being triggered by the brain. The brain fluctuation of hormones and the hormones fluctuating in the body are still going to happen almost on the exact same pathway that would happen in the normal menstrual cycle. And so patients still will ovulate, they'll still have an ovulation cyst, then that follicle will collapse. They may not have the bleeding because the lining itself is suppressed, but all of the hormone symptoms from that actually happen from the ovarian trigger will still happen on things like the IUD. So that's why I think there's minimal effect for things like migraine and for acne and systemic issues that birth control may address when it's taken orally. Okay. And the same thing, patients ask sometimes, okay, if I'm having, for instance, if they're having surgery, if they're having a hysterectomy, but their ovaries are still in, they're still going to have the same hormone swings because the ovaries are the sort of the gatekeeper of menopause, right? And so as the ovaries decline and menopause happens, or perimenopause, which can happen from anywhere from on average, 4 years to 10 years in the US of fluctuations of hormones, extremes. In those transitional periods, there's still wild feedbacks and interplay between all the hormone levels, So I know I'm going on a side tangent. I'm going to be conscious of the time so that we can stick to the goal of offering some pieces of advice. But so I think hormonally, the short answer to that long answer is that there are different options, but it is sort of patient specific on what you've tolerated, what kind of things are an option, if you have aura or not, and then what is available, what can you get by with side effect wise? And then, like you were mentioning before, you have things that can be taken ahead of the days, right? And then you have rescue medications, right?
Yeah, we have as needed medication. Most of them right now work best at the onset of the headache phase. Although now with new research, we have one study that show one that can be taken during the prodrome. So we have as needed, we have rescue in case of as needed is not working. And for those we cheat a little bit, yeah, with the mini prevention when we know it's happening. We do that for months, we do that because people also have to live their life, right? If people know their finals or they have to deal with family over the holidays, like big work presentation, a lot of the headache specialists are also going to use similar techniques, although usually for monthly related, yeah, we tend to prefer the longer acting NSAID. And at least I don't know what you think. Some people said they also benefit from Mantis pain perspective mefenamic acid. So usually that also help with headaches.
Oh,
So
it's interesting. Yeah, we use
doing
it a
that,
lot.
yeah.
Yeah, mefenamic acid or Ponstil, and it's the same timeline. You would actually start it ahead of the cycle starting, so the
Yeah.
day or two before, with a double dose, and then every 6 hours. So those are options. I've seen also a lot of patients that are on injectable medication for migraine now, right?
Yeah.
And those
So
monthly
that's
dosing, or those are.
yeah. Yeah, exactly. So for those with at least 4 migraine days per month or less frequent but very severe disabling, we consider preventive therapy. So these are treatments taken on a regular basis, which sometimes can be daily, every other day, or monthly injections. So the monthly injections tend to be well tolerated. There's a pain of the injection. There can be mild constipation. In terms of OB considerations, they have to stop at least 6 months before pregnancy planning. So for people, that want to consider them, there's a similar mechanism, like in a sense targeting CGRP molecule. There are oral medications, so I like those better for those who may be considering pregnancy. The other thing that we still need more data about, but we need to consider for surgery planning is that CGRP, so to modulate wound healing. So I also try to make sure people don't inject close to surgery if people are planning surgery.
Is that like 2 to 3 weeks? They would.
Yeah, but usually because it's monthly,
Yeah,
we
yeah.
we shift it or we did it. But yeah, that's another consideration.
Okay. And I talked a little bit about, we were talking a little bit earlier, is, identifying triggers, I think is really important for a lot of patients. Audrey, you mentioned that, whether they're nutritional or hormonal, there's a lot of different ways we can tackle that, right? And
Yes,
taking.
and I think life can be difficult enough
Mhm,
without giving up all the things that you enjoy. So our advice would be give up one thing at a time
mhm.
for 6, maybe 10 weeks and see if there's a difference. But if you give up all the little treats you enjoy in life, your life will be a little bit more miserable than it already is. So, from a practical point of view and from a quality of life point of view, I think that makes sense. Just on the question of age and menopause, I do want to strike a note of optimism. As a very proud granny, I can tell you that as we get older, the frequency and severity of attacks reduce, but with age. And we know that migraine strikes at the most productive time in your life, which I think is a terrible cheat.
Yeah.
I mean, it's so unfair. And I have great empathy with women all over the world, but I particularly think that's a very sore blow that in the stage when you're trying to work, have a family, I think up to 49, the stats would show that that's when it's most prevalent. Um, the other thing about managing it and recognizing your triggers, I think maybe being very aware and yet making sure that you're living your life. It doesn't become all pervasive.
Mhm.
That you are you in a myriad of ways. You have other interests. I think Dr. Olivia mentioned ballet, art, all of the things we can do, but it's very hard to think like that when you're in a darkened room. You're
Mm.
on your own and you feel so isolated and you feel you'll never get a handle on this and nobody really cares or understands. Whereas in 2025, we've heard during this webinar of all the expertise there is out there. It's so encouraging for me as a patient and as a patient advocate to know about this and to be aware that there are people with the expertise that you have. And we must, of course, support research.
Absolutely. Absolutely. And I know we could, seems like we could talk for hours, the three of us, but we're always running out of time on these webinars. But I want to give patients, some hopeful notes on where they can find you both, on the organization you work with and what you were mentioning, Audrey, about them looking up the organizations in Ireland as well. Um, and, you know, we have our tech and marketing team that will give everyone sort of a synopsis of this later and resources. So what would be the best place you recommend for patients that are looking for answers, resources wise online, and then Dr. Olivia with how to reach you as well.
Yes.
Yeah. So I think Casey is going to share the link, but there are different links of websites with good information. So we'll share that, but we are both advocates for the Global Patient Advocacy Coalition for Headache. Migraine Association of Ireland has great information on their website. La Voix des Migraineux too, which I know it appears initially in French, but you can click on the right England flag actually, but it's really good translation. American Migraine Foundation. They also have a Facebook group of support Move Against Migraine, and Cassie will probably share information about my office too.
Amazing. And do you do telehealths for patients? Or are you, I know you're in
Well,
Stamford, Connecticut, so how
yeah,
does that work?
Stanford, Connecticut. So happy to do telehealth for people who are physically in the states of Connecticut. When people can, I actually love the in person for different reasons. Probably the same as you. We still need the exam, at least, look in the back of the eyes for the optic nerve. So I think there's still a lot of value in the physical exam. So when people can come in person, I'm always happy to, but I can also do virtual visits.
Perfect. Thank you so much. And we
Thank you.
really appreciate both of you coming on today. It's been a wonderful chat, and I think hopefully very resourceful for a lot of the patients listening. We did get some specific questions, but I think it's hard to do a case review in detail in this kind of forum, but we're happy to look over the questions afterwards. And we can all put our input on it and we will respond to those later. So if anybody has them, that's attended or registered, we're happy to look over those on a later basis. Okay.
Yeah. Thank you so much for having us organizing this. And it's very fitting because endometriosis, migraine are both very invisible, disabling, chronic inflammation, pain disease that tend to be underdiagnosed,
Absolutely.
undertreated, and they feed on each other. So
They
the
do.
more
They
we
do.
work all together, working together as specialists and with patients, the better. So thank you so much for having us.
Absolutely. Thank you for coming.
Thank you. Could I just to add to that, alone we can do so little. Together we can do so much.
Yes.
Thank you.
Absolutely. Well, so lovely to have you both, and I hope you have a wonderful evening, Audrey. And thank you so much, Dr. Olivia. I'll see you back in Connecticut very soon. And for anyone watching, again, submit your questions, and we'll be happy to look through those later. Okay. Thank you so much for being a wonderful resource, both of you.
Thank you.
Have a great day.